Okay guys, let's get started. We are starting on page 3, and what you will see at the top of page 3 is Best Bet for Kids. We're actually going to look at some developmental milestones, which you guys know are really important for NCLEX. I had a whole bunch of developmental milestones on my NCLEX exam because I kept getting them wrong probably. So this information is very important. As you can see, there's boxes, there is activities, and then there is NCLEX tips. So the first age group is 0 to 6 months. What I want you to put in that 0 to 6 month box is the word safety. Yes, safety, because we want to keep this age group very safe. They tend to put everything in their mouth. My daughter is doing that right now. Our NCLEX activity that we will see for this age group. All right, what we expect to see is babbling, rolling over front to back, reflective, smiling and laughing. So if you laugh at a baby, they'll laugh back at you. They don't know why they're laughing. Okay, so we got an activity. You got babbling, you got rolling over front to back, you got reflective, smiling, and laughing. Okay? Underneath your NCLEX tips, you should have the posterior fontanelles closed at 2 months. Posterior fontanelles. What is a fontanelle? Do you know? Right, it's the soft spot, okay, in the baby's head. The one in the back closes at 2 months. All right, think about where the one in the front closes. Do you know? I'll tell you later. Also, the best toy for this age group is a teething ring or a rattle. Teething ring or a rattle. NCLEX might ask you that as well. And don't mind me, I'm looking up and down because I have my notes here. I really want you guys to know everything that I know. Let's move on. The next age group is the 6 to 9 months. And in that box where it says 6 to 9, I want you to put the term object permanence. Object permanence. That means that babies realize that things exist even when they don't see them. Your NCLEX activity for this age group is sitting up without support. Sitting up without support. We also have imitating sound. Imitation of sound. It means that if you say dog, they'll say dog. But they don't know what a dog is. You'll be the dog, the cat is the dog, everybody's the dog. Okay? Also, you will see at this age group, they can wave goodbye, wave bye-bye. You'll see that. Your NCLEX tips for 6 to 9 months are, it is okay to give solid food starting at 6 months. Yes. And the first solid food that we give is what? Rice cereal. Rice cereal. And after that, you can initiate solid foods one at a time. Okay, for a week, and then after that another food for a week. All right, we're being very cautious because we are looking for allergies. Okay. Also, in this age group, an NCLEX tip is that the birth weight doubles at 6 months. So, if a baby was born to be 8 pounds by 6 months, they should be 16 pounds at least. Another thing to remember is that the best toy to give this age group are building blocks or playing peekaboo. Peekaboo. Okay. Moving on, 9 to 12 months. What I want you to put in that box is verbal development. That is very, very important with this age group. So the NCLEX activity for 9 to 12 months is standing alone without support, crawling, and also saying small words. Now, your NCLEX tips for 9 to 12 months are that babies at this age should still be in car seats. Babies at this age should still be in car seats. Also, it is not okay to give cow's milk or dairy milk before 12 months. So, if NCLEX says which statement by the parent is wrong, it's going to be the statement where the parent says, I mix my formula with 2% milk to make it last longer. Okay? Because you are not supposed to give dairy products to kids younger than 12 months. They have a hard time digesting it. All right? After 12 months, you can give dairy products. You can give milk, which milk do you think is better? If you had a choice to give a baby whole milk or 2%, what would you give? You're going to give whole milk because whole milk has a lot of the fats that babies need. Okay? Good job, you guys. Keep going. Okay, 1 to 3 years old is the next age group. In that age group, I want you to put the term parallel play. Parallel play means that babies play side by side. Now, will you see interacting and sharing in this age group? Absolutely not. They are not good sharers at all. Okay? Your activity are the gross motor skills such as walking, kicking, and running. Your NCLEX tips are the anterior fontanelles close at 18 months. Also, there is a huge fear of separating from the parents at this age group. So we never separate baby from their parents. If you have to do an assessment, you always want to make sure that the baby's sitting on the parent's lap. You never want to separate them. Also, you want to do your least invasive procedures first. So we want to always listen to the lungs, listen to the heart before we take a blood pressure or before we start an IV. Okay, and I'm talking about not in an emergency situation, but in a normal assessment situation. You always start with the least invasive procedures first on this age group. Next age group, 4 to 6 years old, what I want you to put in that box is associative play. Associative play means that these people like to pretend. They are really good pretenders, and that's how they learn, by associating things that they're familiar with. Your NCLEX activity are the fine motor skills, such as hopping on one leg, skipping, tying the shoe. These take a little bit more coordination when doing them. Your NCLEX tips are that this age group is very ritualistic. When I say ritualistic, what do I mean? I mean that they like to do the same things over and over again. And that is okay because rituals reinforce safety. So we let parents know that they will definitely grow out of being so ritualistic. Also, this age group tends to be really picky eaters. So they're not going to eat everything. They're just going to want hot dogs and chicken nuggets every day. We also let parents know that that is a phase and they will grow out of it. And what else do I want to tell you about this? Yes. So these are all things that you will see in the 4 to 6 age group. Remember, for your teaching, if you have to teach this age group, you want to make sure you do the procedure on a doll first or a teddy bear, or have them perform it on a teddy bear, because that's how they're going to learn the best way. Moving on to the next age group, 7 to 9 years old. The term that goes in that box is justice play or fair play. That just means that this age group is highly competitive, which everybody knows. If you know a 2nd or 3rd grader, they always want to race you to the door or beat you in kickball or basketball or whatever they're good at. They're really competitive. So your NCLEX activity is group work. Okay, they love group work. Now, your teaching for this age group is, and this is your NCLEX tips as well. At this age, they should be able to brush and floss their teeth independently. Brush and floss their teeth independently. Also, at this age group, with adult supervision, they can give themselves insulin injections and check blood sugars. And I know some of you guys are like, what? Yes, they can, because if you think about juvenile diabetes, this is when it's usually diagnosed, and it is very important for the child to be able to independently do these skills in order to preserve their health. So, highly competitive, brush and floss their teeth alone, and check their blood sugar. Move on to the teenagers. They're super, super easy. Everybody knows that what should go in that box is internalization, and that just means that for teenagers, when they get sick, they internalize everything. The world is about to end. It's all about them and their sickness. So that's what you're going to see. Now, the activity for the teenagers, of course, is peer association. Okay? Peer association and self-development. That is what they're all about. When it comes to your NCLEX tips, know that boys develop 2 years behind girls and typically are 2 inches shorter than girls during puberty. Also, teenagers learn from their friends. You guys know that. And we will get into a more age-specific nursing care in a couple pages south. So let's just stop here for the developmental milestones. Turn over on the next page. I want you to do those questions and then come back and we will go over them together. Let's open it up. Okay, did you guys think those questions were difficult? I hope not. Let's go over them. So number 1 says you have an 8-year-old. He's in the hospital for a broken leg. He requests some activities to keep him busy. Which activities should the nurse bring in? All right, what did you think? Coloring book and some crayons, a few board games. How about a doll? Or how about a video on how to prevent complications from a broken leg? Would an 8-year-old like that? Probably not. The best answer is going to be a few board games. And if you remember what I told you about 8-year-olds, they are highly, highly competitive. So what they want is something that's going to challenge them, something that they can show off their ability to beat somebody else. And remember, if NCLEX gives you an option, more than likely, this is a perfect world in NCLEX, there's going to be somebody there who can play those board games with that 8-year-old. Moving on. A teenager is admitted to the hospital with influenza. The teenager refuses to let his friends come and visit him. Why is that happening? What's going on with that teenager? Well, if you think about teenagers and their internalization and self-development, you would have picked B, his perception of altered body image. And let me break that down for you a little bit more. If you have a patient and they're and they have influenza, which isolation should they be under? Is it standard? Is it contact, droplet, or respiratory? Which one? It is going to be droplet precautions, which means that that patient should have, or visitors, should have on a mask, gown, and gloves when they're visiting. So that's going to be a huge concern to a teenager if his friends have to come and visit him and they're wearing all those things around him. He's going to feel like, oh, look at my friends have to wear all this. So that's why that's the answer. The next question, you got a 9-month-old, you're doing a routine assessment. What are you going to expect to see that child doing? For sure. All right, and that is going to be A, the ability to sit up without support. That is the task that most 9-month-olds should definitely be able to accomplish. Yes, some may be able to say a few words, maybe. Some may be able to stand alone, but for NCLEX, you want to go with the safest answer, which is probably going to be the easiest task. All right, good job, you guys. Let's move on to our next topic. So we are going to get into some more sort of talking about babies again. We're going to look at normal and high-risk newborn, and this is very important for you to know. So the first thing that you see on that page is the APGAR score. And you guys know what the APGAR score is? You definitely should, because it's something that must be memorized. And remember, APGAR is done at 1 in 5 minutes. 1 in 5 minutes after birth. Now, on the chart, there are 5 categories, and within each category, you can get from a 0 to a 2. A 0 to a 2. So let's look at the first category, which is the heart rate. Now, if the heart rate is absent, the baby will get a 0. So put absent in that box under 0. If the heart rate is below 100, the baby will get a 1. And if it is above 100, that baby gets a 2. The next category is respirations. Now, if the respirations are absent, the baby gets a 0. If there is a weak gasping, the baby will get a 1. And if there's a good strong cry, that baby's going to get a 2. The next category is muscle tone or muscles. So a 0 if the baby is flaccid, which means weak or limp. A 1 if there's some flexion. Say if the arms are flexed but the legs are limp, the baby gets a 1. And then 2 if you have a very well flexed baby. The next category is appearance or color. I don't know how I forgot that. Appearance. If the baby is cyanotic or blue, they get a 0. If the trunk is pink but the extremities are blue, the baby will get a 1. And the baby will get a 2 if it is overall pink color or normal color. The last category is called reflex or irritability. And your baby will get a 0 if there is no response at all to any of the reflexes. The baby will get a 1 if there's a facial grimace. And the baby will get a 2 if there is a good response. Now, what do you guys think is more important? An APGAR done at 1 minute or 5 minutes? Which one? I hope you said 5 minutes because that is more valuable. Now, let's look at some categories of the baby after it's born. So in the eyes of the newborn, all newborns should get the erythromycin ointment in their eyes. And this is to protect them from infections such as gonorrhea. The temperature of a newborn should be 98.6, so we are looking for a normal temperature. The pulse is 120 to 160. The respirations are 30 to 60. In the abdomen, there are vessels. There are 3 vessels in the abdomen. No, you guys tell me. I'm not going to tell you. What is it? How many arteries and how many veins are in the newborn? Do you know? What is it? It is 2 arteries and 1 vein. Very good if you knew that. 2 arteries and 1 vein. Okay, the skin of the newborn is very blotchy or spotty, especially the extremities. And let's fill in the blanks at the bottom. Jitteriness and lethargy can indicate hypoglycemia. Jitteriness and lethargy can indicate hypoglycemia. Okay, moving on. Ooh, the drug-addicted newborn on the next page. We're on page 6 now. So, of course, the drug-addicted newborn is any newborn that was born addicted to an illegal substance. What are some signs and symptoms of a drug-addicted newborn? I'm going to tell you. Low birth weight, high-pitched cry, poor sucking ability or poor feeders. Okay, these babies are very irritable. They don't want you smiling in their faces. They don't want to be held. Okay, this is what you're going to see. The nursing care for the drug-addicted newborn is just like the adults. We don't give them a lot of medicine. We actually feed them, we swaddle them, we provide low environmental stimuli, so no heavy lighting, no musical mobiles, no rocking them. Okay, this is how we have to allow them to go through withdrawal, and that's what NCLEX is going to be concerned about. All right, now, the HIV mom. What are our 5 points about the HIV mom for NCLEX? The first point is, what isolation precautions do we use for HIV? What are we going to have this mom under? Contact, respiratory, droplet, or standard? This is very important for safety, okay? It is standard precautions with a cesarean birth, so no vaginal deliveries. The second point is no breastfeeding for the HIV mom. The third point, can the baby stay in the mom's room? What do you guys think? Yes or no? That is going to be yes, totally. The next point after that is the baby cannot receive live vaccinations. Now you guys think about it. What are the 3 live vaccinations that we give? Do you know? I am not going to tell you that one. I want you to look that up. Also, it's in Quick Facts. If you guys have Quick Facts, you can find it there. The 5th point is we give the baby the vitamin K shot. And why do we give the baby the vitamin K shot? What does vitamin K do? You guys remember, vitamin K is going to clot the blood. So that's important for all babies to get vitamin K. All right. There's a question at the bottom of the page. Hit pause and do it. A nursing student is giving a mother with HIV an IM injection. Well, she has AIDS, so she has IM injection. The nursing student sticks herself. What is her priority? What should she do? I hope you guys pick number 3. She needs to start that antibiotic AZT treatment right away. Okay, that is her priority. Don't worry about paperwork. Don't worry about passing out all your meds. You need to start that antibiotic treatment. And AZT is the antiretroviral medicine, and you always will get an antibiotic when you're exposed to AIDS or HIV because you just don't know what other diseases are there. So, good job, everybody. We are moving on. We're going to look at some more birth defects. Turn the page over. We are now on page 7. Now let's talk a little bit more about fetal alcohol syndrome because NCLEX likes to pull this one out of all the other addictions. So children who have fetal alcohol syndrome are typically born with a low birth weight. They will also have craniofacial malformations, which means they will have the flat nose, the very squinty tiny eyes, and the thin lips. These are what you're going to see clinically in that baby. Also, you're going to have heart conditions and heart problems, which we're going to talk about on the next page. You also have difficulty breathing or respirations, and there is a big risk for mental retardation with the fetal alcohol syndrome. Okay, so those are your points that you want to know. The next one is spina bifida. Now, spina bifida is where a baby is born actually with a portion of their spine exposed. Typically, there is a sac around it, and your major nursing priority is to not let that sac burst. So, NCLEX loves to ask you what is the proper position for a baby born with spina bifida. Now remember, spina bifida, let me backtrack a little bit. There's no cause for spina bifida. All right, it's could be genetic, could be environmental. There's no certain cause for it. But like I said, that spine is exposed. So your major nursing priority is to keep that baby in the prone position, which means face down on their belly. Now, whenever somebody's in the prone position, we're making sure that their head is turned either to the left or to the right to preserve their airway, okay? But even when you're feeding this baby, you want them to be in that prone position. What else did I have to say? Oh, also diet is a big concern for both of these defects because the baby may not get enough nutrition. So you want to make sure that the proper diet is in place. Okay, turn that page over. We're going to do some infant heart defects. Now, infant heart defects, you don't have to get too much in detail with this information, but I did want to touch the major points. So when it comes to infant heart defects, there are two types of babies. There are blue babies and there are pink babies. When I say blue babies, I mean that these heart defects will certainly cause your baby to be cyanotic and will have a very severe respiratory problem. The first infant heart defect that I want you to know is tetralogy of Fallot. Tetralogy of Fallot. The second one that I want you to know is transposition of great arteries. And that basically means that the pulmonary artery and the aorta are switched into the wrong positions, so your baby is receiving deoxygenated blood to the body, and that is not great for them. Okay, so you can imagine the problems that they're going to have. The second one is tricuspid atresia, and atresia is just a fancy word for not there. Okay, then the fourth one is truncus arteriosus. Truncus arteriosus, and that means that instead of two arteries, one is trying to do the job of two. So you're actually missing one of the major arteries. They're either the pulmonary or the aorta. Those are your blue baby problems. Now let's look at our pink baby problems. These are three conditions that are major but not as serious. So the first one is ventricular septal defect. The next one is atrial septal defect. The third one is patent ductus arteriosus. Yes. Now, if you look at it, all blue baby problems start with the letter T. T. T stands for trouble. So if you see any of these, automatically think trouble. The best position in an emergency situation to put your baby in is a knee to chest position. Okay, knee to chest position. This is going to help decrease the blood going to the extremities and keep them to the vital organs. We are going to look more in detail into tetralogy of Fallot. If there is any one that you can be asked about, it is probably going to be tetralogy of Fallot. So there's 2 columns. On one column, I want you to put these words, which is an acronym, and it is real oxygenation problem, very scary. So that's how I want you to write it. The first box in the left-hand column should say real. Underneath that, oxygenation. Underneath that, problem, very scary. So the real is going to actually stand for right ventricular hypertrophy. So the right ventricle is very large. The O, or the oxygenation, is going to stand for overriding aorta. Okay. The P for problem is going to stand for pulmonary stenosis. Pulmonary stenosis, and you guys know what stenosis means, hard. And the very scary is going to stand for ventricular septal defect. So those are the 4 conditions that make up tetralogy of Fallot. Alright, you got a question at the bottom here. Oh wait, one more thing. Oh yeah, how should a nurse identify a patient before you give a medication, whether they are an adult or the child? What do you ask for? You ask for the name and